So as part of a routine consultation, patient comes in with a particular, whatever it might be, a bad back or a bad knee, or they might need some medication, but also, is there an opportunity to do something else? For example, maybe address diet or weight.
Many healthcare practitioners are not having conversations about lifestyle behaviors and health behaviors, even when they recognize that the patient in front of them could actually benefit from such a conversation.
There's more and more evidence. There's an increasing number of research studies now that seem to suggest actually, if you talk to patients about health behaviors, particularly if it will benefit an existing condition or kind of what they're there for in the first place, patients actually welcome it. Everybody knows that they need to stop smoking or do more physical activity. Everyone knows that. You can't simply, insult people's intelligence. And so what you need to do is you need to find appropriate targets.
Before we dive into today's episode of the Mental Wellbeing College, an important disclaimer. We do dive into the weeds of mental health, which means that at times we discuss sensitive topics like suicide, self-harm, and substance abuse. If hearing such discussion does bring up distress for you, please do seek the psychological and professional treatment that you need. The content covered in this episode is not intended as a substitute for professional mental health treatment.
Hello everybody and welcome back to the show. Today we are joined by Dr. Chris Keyworth to discuss all things lifestyle behaviour change. Chris is a chartered psychologist, an associate professor at the University of Leeds, and a researcher in all things health psychology and health behaviour change in individuals and from the perspective of healthcare professionals. In today's episode, we discuss why lifestyle behaviours like exercise, diet and sleep are so often not talked about in healthcare consultations and appointments, psychological principles that you can implement to make lifestyle behaviour change stick and make these behaviours habitual for you, how health practitioners can have these lifestyle behaviour change conversations with their patients and clients in a time-sensitive manner, and much, much more. This is a really cool conversation where we talk about things like exercise, diet, and sleep and how we can implement them ourselves, but we really come at it more so from the perspective of healthcare professionals like GPs, physicians, doctors, psychologists, nurses, and how they can have these conversations in a really meaningful way with their clients to instill lifestyle behaviour change. I hope this brings a lot of value to your life, and if it does, please feel free to leave a review on the episode on Spotify or YouTube or wherever you are listening to this episode. This helps us just to iterate future episodes to make them more valuable for yourself and for other listeners. So we'd really appreciate any feedback that you have. Thanks so much for tuning in, and now to today's episode on lifestyle behaviour change with Dr. Chris Keyworth.
Alrighty, Dr. Chris Keyworth, welcome to the Mental Wellbeing College.
Thanks for having me on, Indy. Good to be here.
Yeah, it's fantastic to have you on all the way from Leeds. I've been looking forward to this conversation for a while now. Many previous episodes on this podcast have been on different lifestyle behaviours, from nutrition to sleep, a lot on exercise, but mostly from the point of view of how does it help with mental health, what's the evidence for in reducing depressive symptoms, anxiety symptoms, etc. But to really canvass the evidence of how health practitioners can implement these health behaviours and lifestyle behaviours, I think is a really cool opportunity. So looking forward to that with you today. And in terms of the, I suppose, key terms, let's kind of get those down pat for listeners. So what are we referring to when we say a health behaviour or a lifestyle behaviour? Can you give us a bit of an overview?
Yeah, it's a good question. There's sometimes kind of a little bit of difference in terminology, health behaviours versus lifestyle behaviours. I know it's known as different things in different countries, but in terms of how we think of it in our own research, it's probably quite helpful to think of it in terms of kind of in the context of non-communicable diseases, so NCDs. So these are main ones we think of: cardiovascular diseases, sort of heart attack, stroke, different types of cancers, respiratory diseases. Think of things like chronic obstructive pulmonary disease, asthma, and then diabetes. So if you think of the 4 major risk factors that are associated with non-communicable diseases, we think of these as smoking, alcohol, physical activity, and diet. So, and so modification of those kind of health behaviours can potentially reduce the risk of those non-communicable diseases. So that's how we kind of think of health behaviours. In terms of why it's kind of important, well, just sticking with the NCDs, non-communicable diseases, we know that these place kind of a heavy burden on the healthcare system, both in terms of the cost and the resources. So the cost in terms of managing those health conditions, the resources in terms of people needed to care for the people that present with non-communicable diseases. So, yeah, in terms of defining health behaviours or lifestyle behaviours, as it's sometimes known as, those are the kind of 4 that we use in our research. You could extend that to substance use generally. I know that's another one that kind of comes under comes under that definition, but those are the 4 kind of key ones that we tend to work with in our own research.
Yeah, yeah. And I know in terms of preparing for this conversation, I was reading the World Health Organization, who they estimate about 70% of global deaths are caused by these, non-communicable diseases, chronic diseases. And like you alluded to there, right, these risk factors, these lifestyle behaviors play a huge part in reducing someone's risk of actually ending up with these, or at least delaying the onset of them.
Absolutely. Yeah, it's a great point in terms of, I like to think of it in terms of prevention and management, and you could extend it from non-communicable diseases to other health conditions, and thinking about health in general. So in terms of this idea of prevention and management, so prevention of non-communicable disease in terms of encouraging lifestyle behaviour changes or health behaviour changes in the context of existing health conditions. And that's quite an interesting one, because some conditions may actually benefit from positive lifestyle changes. So, my PhD research, for example, was in the area of psoriasis, which is a long-term inflammatory skin condition. It affects around 2 to 3% of the population. And research, not for everybody, but for some people, research seems to suggest that there are these benefits of positive health behaviours in terms of reducing disease severity. So particularly thinking about things such as weight loss, being physically active, and that so psoriasis is just one example. You can extend that to other health conditions. So yeah, it's quite. I personally think it's quite helpful to think of it in terms of preventing, long-term health conditions, and also helping people manage existing long-term health conditions. So there's benefits, from both viewpoints, really.
Yeah, no, it's really interesting what you bring up, and it's one of the reasons that I was drawn to your research as well, because I have psoriasis. I mean, there's no cure. I'm asymptomatic now, but I had it quite severely in my teens, covered head to toe in plaques, pretty much. And I remember pretty much a common theme my dermatologists, my physicians would say is, you exercise, you're young and you're healthy and fit, keep that up, because that, certainly there's some evidence to show that can help with managing the symptoms. And I feel grateful for that, because it doesn't seem to be the case that these lifestyle behaviors are always talked about as much as they should be. At least that's what I've taken away from your research.
Yeah, that's great. And I'm glad that things that, that you kind of, you've had a positive experience in terms of your own experiences. And that's great to hear. Some of the work that I do is around health communication. So how do you effectively, kind of communicate that information? And clearly, for some people, some health conditions, as you just demonstrated, there are these really positive effects that that you could be experiencing depending on the health condition that you have. So yeah, much of the work that I do is around how do you effectively communicate that. So I guess quite a lot of my work is with healthcare professionals, what's happening in practice, but actually, because there's quite a lot of other much of my other work is around the patient perspective and what do they understand and what can we be doing more in terms of informing people of the benefits. So yeah, it's a great point, and yeah, good to hear that you've had those positive experiences.
Yeah, no, definitely it was a positive experience. Yeah. So in terms of the UK, Chris, you mentioned that you do a lot of research there with health practitioners there. What's the overall vibe, for want of a better word, of the big players, the NHS, for example, in terms of promoting these lifestyle behaviours, these health behaviours? Is it talked about much? Is it promoted much to the actual health practitioners themselves?
Yeah, it's a great question in terms of the priority, and we'll probably talk a little bit about some of the barriers and enablers in a little while. I think the first thing is it's quite a complex picture. It's an interesting question and a complex answer, really, in the sense of healthcare professionals, not just in the UK, but internationally, healthcare professionals are busy. They have a lot to do. And to a certain extent, you hear sort of some healthcare professionals tell us that they don't have time to do this. We'll talk a bit more about the barriers in a little while, but it is quite a complex kind of interwoven kind of picture. So you have these different policy guidelines. So the one that I do a lot of work in is the Making Every Contact Count policy, which is a public health policy in the UK that's been kind of brought in to encourage, support healthcare professionals to use the millions of day-to-day interactions that they have with patients to talk about health behaviours. It's part of something called the NHS Standard Contract, so it's it is in there in terms of encouraging healthcare professionals to address health behaviours in kind of routine consultations. So we have something in the UK called the Quality and Outcomes Framework, so QOF points, which is essentially an incentivisation kind of system. So GPs and other healthcare professionals are incentivised for doing certain things, so recording certain things in practice. So I think asking a person if they smoke is an example of that. There's other examples. But it's very much focused on the recording aspect rather than going a little bit further. So that's the challenge, really. It's this idea of going beyond simply, asking somebody whether they smoke, sort of more provision of information as well kind of would be the next step, to actually going into the realms of what is covered in the Making Every Contact Count policy, as well as other policies in terms of whether it's signposting to support services, delivering a brief intervention. So it's that added extra. So yeah, it's complex, but it's also challenging because I think you have to consider it in the context of healthcare professionals are really busy. There's lots of things to do. We'll probably talk a little bit about how the pandemic has changed how healthcare is delivered. So there are policies that are, Making Every Contact Count is a good example of one. But the challenge really is trying to find ways of incorporating this extra bit of practice, if you like, into an already busy workload.
Yeah. So when you say incentivize through the Make Every Contact Count framework, is that a financial incentive that GPs are given if they do?
So those are two slightly different things. So the incentivization is the quality and outcomes framework. So that's the QOF. So that's completely different to the Making Every Contact Count policy. So QOF is very much around recording, sort of measuring certain things at certain times. And it doesn't just cover health behaviours such as smoking. It's a whole range of factors. Now you've said it, Making Every Contact, actually providing an incentive to do that would be, it's an important consideration. There's some research that has done that, in terms of do financial incentives work. So yeah, I think now you've said that might be kind of a way, certainly an option to consider in research.
Yeah. I mean, it just brings to mind, I suppose, in America in particular, the role of big pharma, in particular with physicians there, and at least the way it's illustrated. I haven't read direct research, but the way it's illustrated is that obviously that has a big influence over prescribing practices of physicians and GPs there.
Yeah, very much so. And yeah, just coming back to the earlier point around the moving beyond this kind of sort of, I guess you would call it maybe a kind of a biomedical model, addressing the primary
Yeah.
symptoms, and then prescribing medication, and then it's very much kind of a maybe a checklist type of approach that getting through the things that are needed within the context of a consultation, and actually going beyond that. Looking at the whole person. Is this, again, we'll probably talk about, I'll keep referring back to this opportunistic element. So as part of a routine consultation, patient comes in with a particular, whatever it might be, a bad back or a bad knee, or they might need some medication, but also, is there an opportunity to do something else? For example, maybe address diet or weight or something else that might, or that may or may not be related to the condition or the presenting symptoms. So, yeah, it's an interesting area.
Yeah, yeah, and I suppose that comes back to your point about prevention and healthcare utilization of different people, right? If we can have these conversations more often, even before a condition presents itself directly related to their physical inactivity or poor diet, there's less likelihood of them potentially presenting again in the future, or at least to the frequency that they would if that conversation wasn't had.
Absolutely. I mean, there's both.
Yeah.
There's kind of, you can look at it in both. I mean, we've done a little bit of work around. We've done surveys with healthcare professionals, and I mentioned earlier we've done surveys with patients or general population. So yeah, the idea of opportunistic is an interesting one, and what we'll talk a little bit more about it later. But in terms of what the patients tell us is they would welcome these discussions, particularly when it's related to if it helps them manage an existing health condition. And I always find that particularly interesting. And it picks up on your point about the patient is there kind of in front of you at that point. Maybe that's a good opportunity to address those factors.
Yeah, yeah. Well, I mean, that seems like a good segue then into some of the barriers. So, reading through your work, and you correct me if I'm wrong, but one of the interpretations that I had through, particularly I think a 2018 survey you did of UK healthcare practitioners, is that many healthcare practitioners are not having conversations about lifestyle behaviors and health behaviors, even when they recognize that the patient in front of them could actually benefit from such a conversation. So this begs the question, why? What are some of the barriers precluding this from happening?
Yeah, it's a great question. It's a big area. So we've done a lot of work on this. There's other colleagues who've done some brilliant work over a number of years. I mean, it's an interesting question when you talk about barriers. We've mentioned a couple of things around workload, but it is an interesting question. And as I mentioned earlier, it's somewhat of a complex answer. I think you probably need to consider it in the context of workload pressures, psychological demands that come with being a healthcare professional. Burnout, for example, is a huge area of research. You probably saw that, particularly during the 3 or 4 years during the pandemic. That was one area in particular that really kind of shot off in terms of the surveys that were being done, the studies generally. So the psychological demands of being a healthcare professional. There's these issues around workforce retention, people leaving roles due to things like heavy workload and stress and so on. Got the added stress of the pandemic, other stessors. So I think it is important to caveat that discussion around barriers and enablers to doing certain things in terms of, here we're talking about delivering health behaviour change interventions, but certainly by saying that being a healthcare professional is demanding, and there's a lot of research over a number of years that provides quite strong evidence for that. But yeah, in terms of the barriers, a lot of these are fairly well established. Some are newer. But the interesting thing is that some of the barriers, or quite a lot of the barriers, are actually present across different healthcare professional groups. So, the healthcare system's complex. There's lots of professionals that work within it across different groups, settings, contexts, different levels of experience, and so on. But yeah, what we find is that there are these different barriers. So commonly reported barriers that you will hear of is this idea of lack of time. I'll probably come back to the GP consultation quite a few times, just because I find it such a kind of a fascinating context. The GPs are the first point of contact, or physicians, with, when patients engage with the healthcare service. They're usually one of the first people that they would see. But the consultation is typically only around 7 or 8 minutes, I think, is that time. There's a lot that goes into that consultation, that 7 or 8 minutes. If you think of the last time you went to a doctor's appointment, I would say maybe 3 or 4 of those minutes are spent, the GP's on the computer. They have to ask about your symptoms. They might be prescribing medication. There might be a referral and so on. So there's not a huge amount of time in that. But, we'll talk a little bit about enablers. There are ways that you can overcome that. There's some really nice research studies that have been done that show that you can actually fit, health behaviour change into that consultation. Things around role responsibility is something that comes up quite frequently. So you go and see your GP or physician. A referral might be made to whether it's a physiotherapist or another specialist. So there could be this idea of role responsibility. It's not my job to be doing this at the moment. Again, primary care is a good one, dealing with the primary complaint. What is the kind of, why is the patient there in front of the healthcare professional? The number one priority is to address that and to essentially make the patient better, for example. An interesting one is this idea of fear of offending the patient. So there's quite a lot of work on the healthcare professional patient relationship or doctor-patient relationship. They might not, the discussions around alcohol, weight, and being more physically active, changing your diet, on the face of it, they might not seem, complex topics, but these are sensitive topics for people to talk about. And so healthcare professionals might think that patients might not want to have a talk about health behaviour change. Idea of lack of training is another one. So actually having the skills, and that's quite an interesting one for the enablers. And then also this idea of attitudes towards patient motivation. So actually, what we hear sometimes is that healthcare professionals report that they believe that patients don't want or need intervention. So, there's a whole list of barriers. But the good thing is that there are enablers. There are things that will help, and there's interventions that have been done. So we do see these barriers across groups.
Yeah. No, those are really interesting, and certainly come to mind the time one, when I go and see my GP. I mean, we're covering, like you said, kind of 3 or 4 different things in 10 minutes. I mean, it's difficult to put myself in their shoes and imagine how you can now, add something to that list often. So, I can certainly empathize, I suppose, with GPs in that sense. But from, my reading, particularly with psychologists, it seems like, so to give you a bit of background, I'm doing my PhD actually on the implementation of exercise therapy or exercise for mental health from a psychologist point of view. So a lot of the key barriers there, and I'm sure you've come across this anyway, but is around that lack of training, given it's really not taught much at all, exercise. But, if I think about my own postgraduate training, there was nothing on diet, very little on sleep, despite these behaviors having a big relationship with many mental illnesses. But then also this other one, which I'm not sure you've come across, but is this concept of therapeutic nihilism, which is they're not going to do it, they won't adhere to it anyway. So why would I bother having the conversation if they're just going to walk out and we'll have a conversation about exercise, but they're just going to go back to their habits of inactivity anyway, which I think is really interesting and perhaps links back to the lack of training and knowledge and self-efficacy that a healthcare practitioner themselves has. If I don't believe that I can actually instill any behaviour change, then I'm going to have that belief that they're not going to change their behaviour at all.
Absolutely, it's such a good point around therapeutic nihilism. This idea of, as you said, that was a really nice definition. The patient is not going to change anyway. It's it's slightly different sort of in the last few years, I imagine, but I think of it as continuity of care sometimes. So it used to be the case where you go and see the GP and you might see the same GP every time. So you build up a rapport, you build up a relationship. The GP gets to know the patient. Not necessarily, well, certainly my experience and the experience of others is that you can't necessarily do that because the waiting lists are so long. So you do tend to see different GPs. But it's an interesting one because you kind of, you build up this relationship as a healthcare professional. And it might be exactly as you said. I know this patient, they've smoked for 20 years. How are they going to change now? And some of the work that we've done previously, we've tried to do some triangulation, so kind of map the views of healthcare professionals to the patients, people who are actually going to these consultations. And there's more and more evidence, there's an increasing number of research studies now that seem to suggest actually, if you talk to patients about health behaviours, particularly if it will benefit an existing condition or kind of what they're there for in the first place, patients actually welcome it and that they actually don't mind the discussion about health behaviours. We did a survey with over 3,000 patients or members of the general public, let's say. It was a general population representative sample, all of which had attended a GP appointment recently, and the overwhelming majority of them said that information across all health behaviours would be helpful and appropriate. So, yeah, I think, as you say, it may be about kind of increasing awareness of that and looking at both viewpoints. Because actually, when you ask, the patients who are attending an appointment, as I said, the overwhelming majority would actually be open to a discussion about health behaviour change. screening. So both routine health check screening, if you like, and also things like cancer screening as well. Again, where health behaviour change might come up opportunistically. And again, there's some evidence from some of those fields that suggest that patients, again, might be open to a discussion.
Yeah, okay. I mean, again, another good segue then, because from the picture that you're painting there, people themselves, patients themselves are open to having these conversations. So what else helps? What else facilitates these conversations about health behaviors, about lifestyle behaviors with healthcare practitioners and their patients?
So yeah, in terms of the enablers, there's some evidence for a number of different studies that actually the effectiveness of behaviour change interventions when offered by other healthcare professionals, they do appear to work, or at least have some, there is promise. They do seem to work across these different health behaviours. So from the work that we've done and that colleagues have done in the area, there's these enablers, so things that help. So, going back to we conducted a review back in 2020. It was this newish methodology. It was a systematic review of systematic reviews, which is a kind of a mind-boggling concept. So the idea of doing one of those is, if you have a particular area, it's a big area, that there are all these different systematic reviews scattered around, but there's no general consensus. You can carry out this systematic review of systematic reviews. So it's a recognised methodology. It's being used more and more. And we wanted to use that. The reason why we felt that was important is because we wanted to bring together the best available evidence across all the different contexts, all the different healthcare professionals, and come up with this general consensus around what works, what seems to help have these conversations. There are a number of barriers that came up in that review, some of which we've already spoken about. And then there are these kind of enablers. So we've mentioned training already. So in that review, healthcare professionals, and these were kind of shared enablers, if you like, across the different groups. So training was seen as something that was really important. Healthcare professionals saw the value of it. The challenge, or the key aspect really, is sort of finding the time in an already busy workload to actually go and attend training, or take part in a training program. But that was seen as important. The environment was an interesting one. So I'm fascinated with the idea of having the right environment that's conducive to having a conversation, potentially sensitive conversation, for example, about losing weight. So I like to think of it, when you think of environment, I like to think of it as a private, if you imagine a private one-to-one GP consultation versus kind of a busy 8-bed hospital ward, where it might be a little bit more difficult to talk to somebody about losing weight or cutting down alcohol, these potentially quite sensitive topics. So the environment's such a really interesting one. Spoken a little bit about the patient attitude. It could be a healthcare professional attitude. So there's some work around having the right workplace ethos around making it an important and valued area of practice. Thinking of things like, buy-in, endorsement from senior managers, feeling supported. We might touch on some of the theories from health psychology and behavioural science, such as the COM-B model, the capability, opportunity, and motivational model. So that's used widely in psychology, as well as other fields as well. It's being used more and more. So we've used this before in that particular context. So it could be about social opportunity. So this idea of support from colleagues and other people to kind of make this a part of practice. And that was seen as particularly important. Access to resources was another one. So knowledge about local support services. So, for example, is there a local weight loss clinic that the patient could be referred to, or an exercise class, or is that what's in the local area? Is there a database that the healthcare professional can access, or resources that could be handed to patients? And that's something that happens frequently in GP consultations, for example. And another interesting one is actually healthcare professionals' own behaviours themselves. So this idea of healthcare professionals being a positive role model and seem to be, a positive influence on patients. So there's a number of different enablers, and it's interesting again that these are shared across a number of different professions working in quite diverse areas.
Yeah, yeah, I find that personal behavior of the health practitioner themselves quite interesting. It's almost a preach what you practice ethos, and the idea being, from what I've read, I think from directly from your work, some of the qualitative work, that the other side of that is that people feel, or physicians, healthcare practitioners themselves can feel almost hypocritical prescribing that if they don't exercise themselves, or even in some data that I've read, qualitative data, like healthcare practitioners saying, well, I'm overweight clearly, so why would I talk to my patient about exercising or poor diet, because it's almost embarrassing for them to be bringing that up.
Yeah, it's so interesting. And again, I keep coming back to this kind of idea of sensitive topics and things that are difficult to broach for a number of reasons. That's one of the reasons I find this area so fascinating, is because you've got this interplay of all these different factors. I was sort of in preparation for talking to you today, and I was thinking back to some studies that I've done previously, and I remembered my very first sort of study that I did. It was my master's dissertation, and I interviewed a group of training nurses. It was a small, modest qualitative study, but I interviewed this group of training nurses, and I remember one of the stories that they told me, and it was around this idea of being a role model for patients. So that study was around training nurses' views on obesity and health behaviour change, and how people with obesity are cared for in the healthcare system. And one of the topics that came up during the interviews was, how are the patients going to listen to what we say when they can see us eating from a box of chocolates behind the nursing station? And it was just something that stuck with me, and that was almost kind of 15 years ago now. But I remember that it was that, as well as other sort of things that came up in that study, that kind of got me thinking about, and it got me very much interested in this area of behaviour change generally. But it's interesting you bring up the practice what you preach, and I always remember that particular story that came up in that research.
Yeah, and you've walked us through really concisely a lot of these enablers or facilitators for having these conversations, and I really appreciate that. And one that stands out, which you've mentioned a couple of times, is that training, the level of knowledge. And it seems like, again, I'll just talk from a psychological point of view, and with my own background and training, again, next to nothing on exercise and diet for mental health, despite, particularly with exercise, several meta-analyses now showing that exercise has equivalent effects as psychotherapy or antidepressants for major depressive disorder. But we get taught a lot more on psychotherapy and none on exercise. But in any case, even in medical training, it seems like there's not much volume of training that a lot of these physicians come out of college with into the real world, so to speak.
Yeah, I mean, it's a real challenge, because as you know from kind of your own work and experience, there's a lot to learn. There's a lot to kind of do. I used to teach in a medical school. I used to run a session on stress, and I used to teach to the medical students. And I always remember seeing the diagnostic manual that is part of their training, and it's this big, thick manual of all the conditions that they need to learn, and all of the symptoms they need to recognise, and how certain things can be detected and managed and prevented. There's a lot to do, a lot to learn. So the challenge really is, how do you incorporate that into their existing training, experience, day-to-day practice? One of the things that we've been working on, one of our sort of current studies, is around developing this brief intervention that can be incorporated into a busy kind of workload. It's based on something called implementation intentions. So this idea of forming if-then plans. So we've run a number of different studies. So we've done surveys, we've done some qualitative development work, and we've developed this kind of intervention that allows people to identify barriers to behaviour change conversations and link those with potential solutions, some of which we've spoken about today. And this is something that can be very easily incorporated into a kind of routine practice. So that's very recent. We're just analysing the data. So we've conducted that over. We've got 4 waves of data for that. So just coming back to what can we do about it? So the key thing really is, do we have something sufficiently brief and effective that we can incorporate into existing training and day-to-day practice?
Yeah. Is there a name for this particular intervention? Or because I'm really interested.
Yeah, so I mean, the particular intervention is based on something called a volitional help sheet. So there's lots of work that's been done in other health behaviours. So all the volitional help sheet is exactly kind of what I've described. It helps people identify barriers to a particular behaviour. So, you know, if I feel that I need to address health behaviours, one of the problems might be the patient might not want a conversation. And then, so a possible solution could be, in that case, I might just refer to a weight management clinic, or I might refer to some resources. So it is an intervention that's been used in other contexts, but we've kind of developed that and so to deliver it online to healthcare professionals.
Nice. I'll certainly be checking that out because, it's all well and good, right, to identify and talk about, like, we have all the barriers and enablers, but that's fantastic that, you guys have come up with that intervention and actually instilling behavior change in the health practitioners themselves.
Yeah.
So that's fantastic. So one of the lessons, I suppose, that I've had as well, Chris, from reading through this literature is many, particularly the physicians, general practitioners, in terms of training, are wanting more training on the process side of things. So I think this comes back to what you were talking about. When I say process, I mean, how do I actually, what behavior change principles do I implement? It's less about when does exercise help, or when does, what are the benefits of not having obesity, for example. It's more about whatever the health behavior change is, how do I actually make that behavior sticky and habitual for them? So, you've run through implementation intentions, which is fantastic. Are there other key behavior change principles that you feel like are really important for physicians and health practitioners to use when they're having these conversations?
So it's such a good point, because behaviour change is complex. It's not just a case of, okay, you need to everybody knows that they need to stop smoking or do more physical activity. Yeah. Everyone knows that. You can't simply, insult people's intelligence. And so what you need to do is you need to find appropriate targets. And this is where I think psychological theories and models come in, and that they provide such a kind of helpful framework for trying to target what the specific drivers are for changing people's behaviour. What are the important decisions that people have to make when they consider changing a health behaviour? And this is why I feel that psychological models are important. So the COM-B model, which we've already discussed just very briefly earlier, it provides this really helpful framework for actually understanding what needs to change to make a particular behaviour happen, or to encourage a particular behaviour change. So what you could do something called a behavioural diagnosis, for example, is one of the early stages that when you're thinking about changing a particular behaviour, you might do a behavioural diagnosis. And that is essentially, that's all about understanding what key factor needs to change. So is it about increasing somebody's skills? Is it about the opportunity? Is it about having the right things in the environment? it's interesting you pick up on the automaticity point, so making something habit, which is one of the key principles behind the intervention that I mentioned earlier. So it's about establishing good habits. It's about making people think that this could happen automatically. And so what the COM-B model does, and other theoretical frameworks, is it allows you to really drill down on what are the key targets. And I think why that's particularly important is because it might allow healthcare professionals then to have more tailored and more targeted discussions. So motivational interviewing is a really nice example of how you could potentially work with the patient to help them come up with their own ways of changing a particular behaviour. So if you think of, smoking is quite a nice example. Coming back to the example earlier around, there might be a particular patient who smoked for 20 years, you could explore that with the patient in a motivational interviewing approach. It could be exploring, okay, so what has worked previously? Have you tried that? No, I haven't tried that. So have you thought about doing it this way or that particular way? So giving them the skills, so you're targeting a particular driver. So motivational interviewing is quite a nice example. It's working with the patient, trying to establish what are the key kind of decision-making processes that they go through when they're thinking about changing a behaviour. And then, just coming back to the theories and the models, it really allows you to kind of drill down what are the key targets for interventions. And that works for both healthcare professionals, so understanding what needs to change from that perspective, and also from the patient perspective as well. So it's understanding what the key targets are there, and it allows this kind of more targeted, tailored approach to designing interventions.
Yeah, I love that. A really person-centered approach that really accounts for where the person is at in their journey, their values, what their missing elements are, rather than a universal, paternalistic, you need to do this, go and do it approach, which is obviously not very useful. So yeah, really cool. And Chris, it's been fantastic to speak with you, to go through your research. It's been really influential for my own practice as a psychologist, for my own studies that I'm planning to run. Reading through your work has really helped shape a lot of the thinking there. I am anticipating a lot of benefit for particularly the many students who are future practitioners, either in medicine, psychology, or other, and indeed the practitioners themselves tuning in. So just a big thank you on behalf of myself and them for the work you've done and for sharing your wisdom today.
Great, yeah, it's a pleasure. Thanks for the invite, and yeah, good luck with the podcast. It's a really, really great and helpful resource.
Thanks so much for tuning in to today's episode of the Mental Wellbeing College. If you've made it this far, it means you've gleaned a ton of value from today's episode, or you've fallen asleep. I sincerely hope that it's the former, and if it is, I would be so grateful if you were to hit subscribe, follow, or to share this podcast with someone you care about. Our mission here at the Mental Wellbeing College is to provide a free and accessible resource for people to take action and implement to improve their own mental well-being. And you subscribing, following, and or sharing helps us to achieve that mission and to impact people in need. Thanks so much for tuning in. It means a lot. We'll see you next week on the Mental Wellbeing College.